We have, as part of the podium's discussion, two presentations. Elizabeth will, in the context of evaluating the options, where we not only evaluate the heart function, we have to evaluate the whole context of a person's illness, including the family and the support system, in order to come to a good recommendation. And Elizabeth is sharing with us thoughts and actually also research project intentions of how to best do this. It is very challenging. Elizabeth.
Well, it's a little intimidating following such eloquent speakers and powerful stories. So forgive me if we slide back a little bit into sort of lecture mode for a few minutes, and then we'll get back to the real meat and potatoes, which is the best part of this day, and that's hearing from our patients. So we so appreciate our guests generously sharing their journey and their insight. And we marvel at the tenacity, the bravery, and courage it takes for our patients and their families to maneuver through the transplant experience despite sometimes insurmountable obstacles. And I feel so fortunate to be part of a very dedicated team of clinicians, practitioners, and nurses in the UCLA Cardiomyopathy Center and the Heart Transplant Program. And in our role, we have the unique opportunity to help care for our advanced heart failure patients who often require evaluation for heart transplantation and ventricular assist devices. Patients referred to us come from diverse backgrounds, ethnicities, and socioeconomic stratas. And clearly, from the stories we have heard shared today, we recognize the demands are high, and it takes a village. So today I'm here to talk about the psychosocial risk and its role in the transplant process. And here are my objectives. Now, we all know that heart transplantation really remains the gold standard treatment and the most successful long-term option in advanced heart failure. But its utility is limited by donor supply. A large disparity between those transplanted and those on the waiting list continues. And while the overall survival rate for those transplanted is nearly 90% after 1 year and 75% after 5 years, the reality is a number of patients will die or become too ill to be transplanted while waiting. And the scarcity of the donor pool makes the selection process criteria critically important. Now, in their 2010 white paper, the Organ Procurement and Transplant Network and the United Network of Organ Sharing Ethics Committee provided a general consideration and assessment for transplant candidacy, which stated because donated organs are a severely limited resource, the best possible recipients should be identified. The probability of a good outcome must be highly emphasized to achieve the maximum benefit for transplants. Now, the selection process should be considered a continuum from determination that a patient suffers from end organ failure to the assessment for transplant to screening for medical and psychosocial fitness for transplant. And while minimal medical criteria for transplant listing are well established, psychosocial criteria are broad and less standardized. But we have to remember that this process can be fluid, that in medical and psychosocial contraindications, they may be relative and not absolute, but require ongoing interventions, treatment, and surveillance to improve a patient's candidacy for transplant. Now, the need for psychosocial assessment is widely recognized by our core professional and government agencies related to transplant in order to establish best practices. So UNOS specifies that all transplant programs identify appropriately trained individuals whose primary responsibility is for coordinating the psychosocial needs of transplant candidates. ISHLT recommends that psychosocial assessment should be performed before listing for transplantation. The Department of Health requires that prior to placement on a center's wait list, a prospective candidate must receive psychosocial evaluation. And lastly, CMS mandates that an evaluation process is part of the set of requirements in order to be approved as a transplant center. So really, what are our goals? Well, truly to promote fairness and equal access to care, to maximize optimal outcomes and wisely use scarce resources, but ultimately to mitigate risk, optimize graft and patient survival, functioning, and quality of life. Now, in the literature, the data does suggest that there's a strong association between pre-transplant psychosocial factors or vulnerability markers and post-transplant outcomes. So let me take you through a couple of examples. In this study, 108 heart transplant recipients were followed for 970 days, and they looked at psychiatric risk factors that were hypothesized to be related to post-transplant hospitalizations, infections, and death. And the risk factors that they assessed for were recent substance abuse, history of suicide attempts, having a personality disorder, low levels of social support, or a history of poor adherence to medical regimens in the past. And then patients were classified to a good, moderate, or high-risk category. And the results showed that patients classified to the high-risk category had a hazard of death greater than 2.5 times that of the acceptable or good candidates. So here are the variables that were associated with this high-risk category, but the results indicated that previous suicide attempts, poor adherence to medical recommendations, previous drug or alcohol rehabilitation, and depression significantly predicted attenuated survival times. And while the increased risk classification was associated with increased hazard of patient post-transplant mortality, it was not predictive of infection or hospitalization. Now, in this study, 145 heart transplant recipients received a detailed compliance and mental health assessment during the first year post-transplant. And the outcomes they measured were acute graft rejection episodes, incident CAD, and mortality, and these patients were followed for up to 3 years. And the results showed that acute graft rejection was 4 times greater for recipients that were not compliant with medications, that there was an increased risk of incident CAD for recipients who had persistent depression, persistent anger or hostility, medication non-compliance, or obesity. And lastly, there was increased risk of mortality if recipients met criteria for PTSD that was related to transplant. So we understand why psychosocial assessment is so important and how it can relate to post-transplant outcomes, but what's the process? So typically, our patients are referred by our esteemed outside cardiologists and community physicians for evaluation for transplant. Then the patients and families must endure a rigorous process that is feeling pretty invasive microscopically, and I mean that figuratively and literally. And while our psychiatrists and social workers play a pivotal role in the psychosocial assessment, the pre-transplant evaluation is really a multidisciplinary team approach, with each team member evaluating the patient to assess suitability for transplant. And the team members may encounter patients and families at various time points, so continuous dialogue regarding changes or interventions is key. Now, there's no question that undergoing a transplant is complex and challenging physically, emotionally, psychologically, and affects not only the patient, but their entire family or support system. And receiving a transplant is a gift, and it's our obligation to the generosity of our donor families and to the success and survival of our transplant patients that we identify preventable and treatable problems prior to accepting them for transplant. So our rationale for psychosocial screening should identify comorbid mental illnesses, identify patients' social support network, predict a patient's ability to cope with the stressors of receiving a transplant, establish baseline measures of mental and cognitive functioning so we can monitor that for post-op changes, and ensure there's adequate education and understanding of informed consent. So based on the rationale, a formal psychosocial assessment is performed by the psychiatrist and the social worker through consultations, and this includes the past psychiatric history, any current psychiatric issues or problems, the use of psychotropic drugs, substance abuse history or substance use history, social support, cognitive evaluation, and their knowledge and understanding. And from this, psychosocial risk factors can be identified, reviewed by the selection committee, recommendations made, and then treatment plans developed during the waiting, recovery, and rehab phases of the transplant process as necessary. So recently at UCLA, we wanted to look at a way to enhance the assessment of patients being considered for transplant that may assist in a risk stratification of patients best suited for successful outcomes. And as we explored the literature and the assessment tools to adjunct our evaluation, we were very interested in Dr. Jose Maldonado's work at Stanford in the development and testing of the CPAT, which is the Stanford Integrated Psychosocial Assessment for Transplantation. And this was just formally published in March 2012. And what we were really impressed with is that the CPAT was developed from a comprehensive review of the literature and clinical practice, which identified evidence-based risk factors that impact transplant outcomes. And the tool itself is an 18-item standardized assessment instrument, and it's separated into 4 domains. So first, patient readiness level and illness management. So does our patient understand what's made them so sick, and do they really understand how sick they are? And do they understand the transplant process? Do they want a transplant? Is there willingness and desire? How has their adherence or compliance been in the past? Did they miss clinical appointments, forget to take their meds, those kinds of things? And just looking at general lifestyle factors. Then again, a review of substance use, abuse, and dependence issues. So this is looking at alcohol, nicotine, illicit drugs, for whether it's been used recently, a long time ago, et cetera, and looking at the risk of recidivism. Social support, which I don't think any one of us can deny is not one of the most important factors, and we've heard the stories today. But is there adequate support for our patient to get through transplant? And what's the function of the social support network that they have? And also we have to consider appropriate living space and how far someone lives away from the transplant center. And lastly, the psychological stability and psychopathology. So is it present? Was there a history of it? Is there any kind of neurocognitive impairment, personality traits or disorders, and truthfulness versus deceptive behavior? So as one works through the tool, it provides an overall risk severity score of psychosocial factors that are important of predicting success. And as you can see here, the greater the score, the higher the risk category, which provides a corresponding recommendation for listing. So in the testing of the tool at Stanford, there were 5 examiners that blindly applied the CPAT tool to 102 randomly selected liver, heart, and lung transplant patients. And then the predictions made by the CPAT score were compared against actual outcomes. And they measured a negative outcome as one or more of these conditions: difficulty with treatment adherence, an unstable social support system, substance use recidivism, development or relapse of a psychiatric problem, or graft failure. And a positive outcome was just the absence of any of these. And the CPAT scores were highly predictive, as you can see, of the transplant psychosocial outcomes. And the other benefit was the instrument itself demonstrated excellent inter-rater reliability. So currently, we're conducting our own evaluation of how the CPAT scores may be predictive of transplant outcomes with a retrospective study of heart transplant experience here at UCLA. So stay tuned for our data next year. But please keep in mind that the tools are meant to enhance the psychosocial evaluation and help standardize it, but never in place of the process that currently exists. And Dr. Kaderis actually brought this article to my attention, that while all centers have sort of absolute and relative contraindications for listing outlined, we need to recognize that these may be open to change. This was recently published, or at least in 2011, regarding early liver transplantation for patients with severe alcoholic hepatitis. And typically a 6-month abstinence from alcohol is usually required before patients with severe alcoholic hepatitis are considered for transplant. And patients whose hepatitis is not responding to medical therapy have a 6-month survival rate of about 30%. And since most alcoholic hepatitis deaths occur within 2 months, early liver transplantation is attractive, but it's pretty controversial. So in their study, the cumulative 6-month survival rate was higher among patients who received early transplantation than among those that did not. And the benefit of early transplantation was maintained through 2 years. So, we sometimes have to look at some of the criteria that we've laid out. So in summary, psychosocial factors we see can impact post-transplant outcomes, and assessment tools can complement and standardize the process. But it's really imperative that we provide at-risk patients with appropriate treatments or services before transplantation, with the goals of improving function and quality of life. Now, some of the interventions that might be helpful, and that Danetta did a nice job of summarizing, as did our speakers, is that it's important for us to create those treatment plans that are patient-specific and family-specific. But participation in things like transplant support groups, caregiver support groups, patient-to-patient mentoring, maybe internet and online transplant support networks for some, participation in transplant-related programs. And lastly, one of our other social workers brought forth the idea, when I spoke to her the other day, of how important it is to have patient evaluations of the process. You rate us. Let us know how we can do better in the future. So despite the fact that science and medicine is data-driven, when addressing psychosocial variables, I think we must appreciate what our dear friend Albert Einstein says, in that everything that can be counted does not necessarily count, and everything that counts cannot necessarily be counted. So moving through the transplant process can be turbulent, and it is our job to assist our patients and families with the support and the interventions necessary to get them safely to the other side. Thank you.
I wanted to ask Ilan and Judith and Anne, who had the experience of a mechanical support device, and you went through the evaluation in different ways. I think for Judith it was a rapid course, and I wanted to ask you and Ilan, and then in context of what Elizabeth just outlined, the criteria of having to have 2 caregivers available. How was that from your perception, while at the same at one time on one hand waiting for a kind of life-saving procedure? Was there any moment where you felt, okay, hopefully we fulfill the criteria, or did you always have a certainty that that was in place?
Well, I was terrified of the BIVAD, just absolutely terrified. And I knew that I needed it to keep me alive because my heart was not working properly. And I was in such a weakened state that they couldn't even put me on the list for a transplant until I got my strength back. So it was a little bit of a, not so much a catch-22, but I was sort of stuck. But as uncomfortable as it was, I mean, clearly it saved my life, so I'm very appreciative to the BIVAD team. But I think what the doctor's asking is, because of the BIVAD, I needed somebody with me 24/7. And so, and how did that make me feel? Nobody likes to be dependent on other people. I mean, it's a very awkward situation. I mean, clearly the medical staff and the nursing staff were just wonderful, but that's what they're there for. But the stress that it put on my husband, the plan was that I would get strong enough and eventually go home with the BIVAD while waiting for a donor heart to become available, and mercifully that did not happen. It actually went fairly quickly. Once I was actually put on the transplant list, I was still in the hospital when a heart became available. But we did have a few of my friends come by and my husband to go through training sessions in preparation to send me home with the BIVAD, because you can never be left alone. You know, you can't just, I'll just unplug it for a minute and go to the bathroom. I mean, it's your heart, and someone needs to be there at every moment if there's a power failure, if the tubes kink, if the battery runs out. So I was very fortunate that in addition to my beloved best friend, wonderful husband caretaker, in addition to that, I have some very, very good friends who just, tell me what you need and I'll be there. And they came to the hospital and were ready if I needed them. So to come full circle, how did it make me feel? It made me feel horrible. I hated being dependent on other people. And also eternally grateful that I had people around. I've been to the support group that Danetta runs, and it's just horrifying to hear people say that they don't have friends, family, a team. I mean, I'm blessed in many, many ways, but in that one way specifically. I'm not sure if I've answered your question, but.
So one of the things that we do request, so it's not a hard and fast requirement that people have 2 caregivers available to them, but we do request it. And one of the reasons, and I hope Ann and Nick can speak to this, is that it's a huge responsibility for somebody to be available to be with you 24/7. And Nick, I know you carried a lot of the responsibility yourself for taking care of your mom. But just so maybe you could speak to that, because so they never got to go home, but Ann did go home, and Nick was really wonderful and provided most of her care. So.
Yeah, I was with my mom. I was with her because I actually live with her, and I was with her from the very moment that that she was admitted to Torrance Memorial, which is where we live in Torrance, and they put a device, a defibrillator in her, and they pretty much they didn't give her very much hope that she was gonna, that there was really nothing they could do for her, and it just left us all wondering what was going to happen to her. And they hit a wall, and one of the doctors referred her to Dr. Hickey at UCLA Medical Center, and within months she got her LVAD, and it was just from the very minute she got her VAD, I could see like life in her face, and it was amazing. And time progressed, and she started to get stronger. She got up and started walking around, and it was amazing. She really came a long way, and with the help of Newman helped out tremendously with our family, and he taught us how to use the VAD, and just going home with her was more than I could ever ask for. The day that she came home with us, and it was kind of strange, like getting used to all the bells and whistles on the VAD. Like I knew she was okay, like when the light on the beeping noise on the VAD would beep, and it was like a long sound, and it would stop. I knew she was safe. She'd plug herself in at night, and she'd be fine until the morning. And this was just a continuous process. She'd have to take medication throughout the time of being a VAD patient, and we were just on top of things. We couldn't treat it like it was not serious, because it was very serious. And I think that we did pretty well. As a family, we all held each other together. My grandfather Maury, my grandmother, we were all there for her, and it led us up to the point where she was ready to have a heart transplant. It was basically a bridge for her new life, and without the VAD, I don't think I'd see her here with me today. So I just thank the family that gave her the heart, and we haven't even sent them a letter because it's just very sensitive, We don't know how to approach it, but we thank the family. I'll let you talk.
My two children here have really, well, I have three. They have gone through so much with my transition. And during the stage of me having my LVAD last year in April, well, December, my husband was diagnosed with 4-stage colon cancer. And that really scared my children. I mean, that was just something they had not expected. And here I was the sick one, I was the one that was getting all the attention. And now their father, had something that was also terminal. And in April of last year, I was listed for my heart. And it was very, very hard because here he was sick, dying on, his last stages, and I had to hold strength and keep my head up, and really I leaned on to my son and my family and my mother and father, and it was really hard. Anyway, he passed away in April, and especially my youngest one here, she really was close to her father. Well, they all were, but she had a really, really hard time dealing with it, and it was hard for me to even talk to her about my own problems. I really felt it was something I couldn't even share, because it was like more heartache for her to have to deal with, and so I had to be strong. I didn't think I was as strong as I was, and if anything, this whole thing has really given me a lot of strength, to pull through, keep my head up. And I knew that when I went in for my heart transplant in September, that's when I got approved, or the heart came in, that I was going to go in, get my surgery done, and I was going to come right back out, and I was going to look at my kids, and I was going to say I made it, and there's no question that I wasn't going to make it, and here I am, and I just feel like it's just pushed me to just have this positive, motivation and drive to keep moving forward, and I have this passion for my artwork that has also carried me through, and it's kind of like calmed my head inside and made me realize that life is really beautiful. Hold on to it, and there's going to be another side, and there's good things awaiting for me, and I know why I'm here, and I thank my donor family. I haven't contacted them yet, only because I need to get strong inside to be with them and talk to them if they do need to talk. If we need to talk about things. I don't want to break down and cry on them, and because I know for me it's been happy to accept this heart and be given this gift of life, and for them, it's the loss of their son, and even though I know I'm so grateful they gave me their son's heart, I just can relate that to my own children, and to share that with someone else. I just can feel that, and I just know that when it comes time, I'll be ready to write my, my note to them, and and it'll happen, and that's what I have to share.